So the understanding basically is to help us to treat it better. So just a few words about the entire spectrum of primary angle closure disease. That if we look at all the surveys that have been done in India, the number of patients with PAC and PACG equals those of POAG, if not exceeds those. And blindness, as we see it, is 20% of all the patients who are coming to us in any of our OPDs. So what causes this? It's the anatomy and the physiology. I think anatomy everybody understands, it's a small eye. But what is more relevant is that this seems to be actually inherited. So in families, you'll find almost 50% of the immediate family members will have similarly small eyes. So this is one way in which we can catch it early. What we do know is that there is an additional physiological element to this which causes the iridotrabecular contact.
Ma'am, there's an echo. I'm so sorry to interrupt. There's an echo which they are trying to sort out. Just for a second, ma'am.
Thickening of the lens, or you get uveal expansion pushing the lens forward. So all these things will allow more of the iris to come into contact with the trabecular meshwork. And when you put these two things together, the cause of the angle closure in 100% of angle closure eyes to a smaller or a greater extent is pupillary block. In about 8 to 23%, and this is pretty much the same for plateau iris, exaggerated lens vault, and a prominent last roll. So please always remember that you may have a plateau iris, you may have a lens vault, but they also have an additional pupillary block element. And this iridotrabecular contact is what ends up causing damage. If you look at the first picture over here, you can see the very clear trabecular beams and the large spaces between them. This is a patient with acute angle closure. You can see the inflammatory cells, you can see the thickening of the trabecular meshwork. And this is a primary angle closure glaucoma where the entire thing is just fibrosed over. So there is increasing trabecular dysfunction as we go. So if we could stop a patient with primary angle closure suspicion at this level, the trabecular damage should not occur. So the iridotomy, as I've said, 100% of angle closure eyes have some element of angle closure of relative pupillary block. So an iridotomy has to be done, and the ideal is to have a mid-peripheral iridotomy. Make sure that you do a gonioscopy after about 6 to 8 weeks. The iridotomy is not being done to lower IOP. It is being done to prevent further pupillary block and the attendant fluctuations in IOP that occur with this pupillary block. So why do we do it in angle closure glaucoma? You can see that this is the anterior segment OCT 360 degrees of an eye before an iridotomy has been done. And you can see how high these iridotrabecular contact goes. And when we do an iridotomy, you can see it all falling back. So parts of the trabecular meshwork now become sort of exposed and therefore may allow a medical control where otherwise it would not be possible. So when we look at classifications, I would say for clinical use, we have those who are suspects, just the anatomy. We have those that show us iridotrabecular contact, which is primary angle closure. So there is a beginning of trabecular damage. And then we have those who are primary angle closure. That means there's evidence of angle closure, and there's an attendant rise in intraocular pressure. And it is these patients who actually develop the neuropathy. So if we actually look at this spectrum, you can see that we could actually stop this from progressing by doing an iridotomy here, by reducing the IOP here, and further reducing the IOP here. So if we go ahead to the clinical examination, please remember the easiest thing to do is to look for a shallow anterior chamber. This is one way that we've all been taught, but very often there's a arcus senilis and we can't do this. So you can do a similar thing just in the inferior limbus to get an approximate idea of what is the iridotrabecular or iridocorneal angle. In an open angle, what we would look for is to see the corneal wedge and a great distance between the most peripheral iris and this corneal wedge. In angle closure, this becomes very close. So instead of seeing all these areas of the trabecular meshwork, in patients who have occludable angles and evidence of ITC, you see some and you may not see the others, and in some it may be completely closed. So how do we do the gonioscopy? You make sure you're doing it in a slightly dark room. You want to use the thinnest beam of light possible, only 1 to 2 millimeters of height so that it doesn't touch the pupil. And here you can see that, with the very short beam, this looks like as if, this is the Schwalbe's line, and the distance between Schwalbe's line and the iris is very close. If, however, you allow the light to fall up to the pupil, and you can see this absolutely flattening out, the curve over here is flattening out. So be careful how you do the gonioscopy. In primary angle closure disease, we've just been through the subtypes. What are we likely to see? An absolutely normal trabecular meshwork in suspects, some filiform synechiae, blotchy pigments, or evidence of synechiae in patients as we progress towards the spectrum of primary angle closure glaucoma. So, the management of these patients in angle closure suspects, as I said, if we do a iridotomy in high-risk patients, that means all fellow eyes of patients with primary angle closure disease. Those who require frequent dilation, patients living in remote areas, we can actually prevent this progression, which seems to occur in about 20%. And the iridotomy has been shown by the ZAP study to be very effective, even despite the fact that they actually removed the patients who were more likely to develop angle closure. What happens when you see evidence of angle closure? All these blotchy pigments are telling us that the iris was attached there at some point and has fallen back, or there's a very narrow angle, and you can see the associated loss of the pupillary ruff. If you see this, again, the first thing to do is an iridotomy. 2 weeks later, please do a diurnal phasing to actually see whether the IOP is within normal limits or on the higher side. And if all is well, you do a baseline perimetry and imaging and see the patient every 6 months. That likelihood of progression in these eyes is between 20 to 30%, which is quite high. So you must make sure that these patients follow up regularly. What happens with the similar kind of path that can be seen, maybe more extensive? The disc is still looking okay. So we would term this primary angle closure with an ocular hypertension. And the diurnal phasing after the iridotomy will show us raised pressures. We rule out the presence of anything else like plateau iris or a lens vault. Again, we use medications to lower the IOP to less than 80 and then review every 6 months. What is the likelihood of these patients progressing? Once they've actually progressed from just one synechiae to a point where there are multiple synechiae and raised pressures, the chances are 20% of them are going to develop a visual field defect. And finally, angle closure glaucoma, as you're aware, comes in two types. Acute angle closure, I think we don't need to talk too much about it, but intensive medical therapy first, topical, oral, and IV, followed by pilocarpine, will allow constriction of the iris in almost all patients. A laser iridotomy can be done once the eye actually quietens down. You could do an iridoplasty if required. Most patients, if they come early, they do reasonably well, only about 10% of them getting a visual field defect. But in India, unfortunately, most of them come to us late, and we have to then wait for a while and do an iridotomy, and 50% or more are controlled with just an iridotomy alone. About a quarter need a trabeculectomy to control the IOP. This is the iridoplasty that has been done in this eye because it didn't actually open up, even the AC wasn't deep enough even for us to do an iridotomy. Once you get to the stage of chronic angle closure glaucoma, just think that once you've done an iridotomy, it's just like POAG eyes. So you have to use medications, trabeculectomy, etc. to get to a target IOP. Keep looking at these. This is what the trabecular meshwork looks like. There are no spaces in primary angle closure glaucoma at all. So it is better to try medical control, and if the baseline IOP is less than 30, medical control generally does well. More than 30, we quite often need surgery. And as you are aware, I think Ankur has presented very well early, moderate and severe sort of classifications of field defects. That helps us to actually put forward a primary target IOP, that this is what we would like. After a year or so, this needs to be reassessed because sometimes you might find that in certain individuals it will remain stable even if the pressure is slightly high. And in certain individuals, it will progress even if the IOP is within your target limit. So reassess after every 1 or 2 years. In primary angle closure glaucoma, what we have seen is that progression will be only 1 to 2% if you lower the IOP to the target IOP that we have spoken about. Trabeculectomy is very safe and effective, better done with releasable sutures, and over 10 years we've seen that there's an absolute success and a qualified success of more than 90%, even if we wanted intraocular pressures of target IOPs of less than 12. So the AC reformation is required in a few, increase in cataractogenesis in about 4%, and we still found that there was perimetric progression in about 1.6%. So it works, but it needs a follow-up as well. What about cataract surgery? I think everybody would love to do a cataract surgery, because what happens is that you see this really narrow anterior chamber, you take off the lens and this is what it looks like. But I'm reminding you again that actually, even if you do this, this is cosmetic. The rest of the trabecular meshwork here is not functioning at all. The Eagle study, which everybody quotes, writes very, very categorically that the difference between doing only an iridotomy and doing a clear lens extraction, the IOP difference was only 1.18 millimeters. And the authors themselves had said that this is not clinically significant. So please do not quote the Eagle study to do a cataract, a clear lens extraction or a cataract surgery in either PAC or PACG eyes. More importantly, a lot of them seem to lose vision after cataract surgery. What are the suggestive effects of phaco? They say the ultrasonic changes may wash out debris, mechanical widening of the angle occurs, and in the best hands, the IOP fall has been 2 to 8 millimeters. This is, of course, much larger in acute angle closure eyes because they start at 50 and 60 millimeters of mercury, and you remove the lens, and the iris falls back before trabecular damage can occur. In PACG eyes, please remember the pressures that we actually see are 30 to 40 millimeters, and a 2 to 8 millimeter drop still requires medication. So please do not do a cataract and say no medications are required. Please follow them up regularly. A phaco trab has been shown to be better than phaco. And when we talk about a prognosis of primary angle closure disease, I come back to a lady who's 50 years old, has primary angle closure, and at that time itself, we do an iridotomy. And we take a cohort of similar patients of 100 patients at 50. By the time they are 70 years old, they have actually come to a point where there is ocular hypertension. These are the yellows in so many, and we treat them well, and nothing is going to go further. But 1 or 2% are going to progress, and these are the 6 out of the 100 who with 30 years are likely to get just an early visual field effect. So to conclude, please screen families. Even if one patient has primary angle closure disease, check the others out. When we do biometry for cataracts, please use that also to screen for angle closure glaucoma. An Nd:YAG iridotomy is a must and safe in all primary angle closure disease eyes, even primary angle closure glaucoma, as I have explained to you. Review primary angle closure without a raised IOP once a year. Those with ocular hypertension, reduce the IOP and follow them up every 6 months. Primary angle closure glaucoma with a visual field defect and neurological damage, please the target IOP as per perimetric damage. Remember that the cataract surgery cannot reverse trabecular damage or the raised IOP. So whatever you may want to do for visual return, a visually significant cataract surgery, in these eyes, you must follow them up and give medications as required. I would like to thank all these people who were responsible for the many years of the angle closure glaucoma studies we've done. Thank you.
Thank you, ma'am, for the outstanding oration as always. Ma'am will probably be leaving us after this. So if there's a quick question for her from the audience, please use the mic in the aisle. So it's a full hall, ma'am, and many people are listening online. I think they've really understood your talk very well. And
I hope they've got to the point where, shallow AC, do a gonioscopy, do an iridotomy.
Yeah,
then follow the patients up for any raised IOP.
And also, ma'am has suggested in one summary word that it's a more aggressive process than open angle. Will that be a good comment, ma'am?
Yes, I think the difference being that we start with higher IOPs in angle closure glaucoma, and therefore I think that the visual fields progress much faster and more sort of in a larger percentage of patients. But if you do an iridotomy, get to your target IOP, as I've said, 1 to 2% progression, I think is something that we would all accept.
Thank
Ma'am,
you.
just one question. In some of the chronic angle closures, where the angle seems to be almost totally closed, and there's no obvious iris bombay, or we are not too sure about the pupillary block element, and some of our eyes are heavily pigmented, would you suggest this thing? But if one is going, is it a must to do iridotomy in those kind of situations?
As I showed you with that ASOCT picture, what happens is that when there is, as you say, looking as if it's completely closed, some areas are actually going to have synechiae. Other areas just have a steep iris beyond which we can't see. So if you do an iridotomy, that iris falls back. So a significant part of the working trabecular meshwork may get opened. It's a may, but what it does is it prevents any further attacks. I mean, you can sort of decide that, okay, I'll only give medications, I'll give timolol, I'll give prostaglandins and whatever, pressures are controlled. But every time the patient is stressed, if the patient is in a dark room, that pressure is going to go up and down, regardless of how well you're controlling the iridotomy. So for both these reasons, it is important that one does an iridotomy. And what we have seen in RP Center in the past, that there were patients in whom we were sure that this was going to require surgery. But we did an iridotomy and we found 1/3 of them were actually very well controlled on medications, and only 2/3 of them required surgery.
Thank you, ma'am.
Thank you so much, ma'am. Thank you so much for your time and your presence virtually. And we can move on to Dr. J.S.
Question, David.
Yeah, so we'll just have time which is running out. So
Sure.
okay, for ma'am you can, because she'll be leaving. Sorry. Yeah, go ahead.
Just want to know the role of pinhole pupilloplasty in SFT and angle closure. Since it's been
The role of pupilloplasty, if they'll put my presentation up again, I'll show you what an iridoplasty looks like. This is what an iridoplasty looks like. All right, and this was, as I said, an eye where the AC was so shallow we couldn't do anything else. But there's a lot of iris sort of atrophy that occurs, and every time you do burn the iris, there's a lot of pigmentation that is released. So yes, it does deepen the AC to some extent, but in the long term, you still require a lot of medications for control. Coming to SLT, there are a lot of people who said that yes, you do an iridotomy, lower the general sort of steepness of the iris, and if you can see enough of the posterior trabecular meshwork, you could try SLT. The effects are not as good as POAG or juvenile glaucomas, but it is a possibility.